morning, Dr. Patino here at the Cosmetic Surgical Cerebral Serena. We're gonna do micro power assisted. Power assisted is like a toothbrush, electric toothbrush, right? So the tip moves by itself. I don't have to do much, but if you have this power tool, you know, you're supposed to brush your teeth like just like this, very gentle, right? If you brush your teeth with an electric toothbrush and you're jamming the toothbrush back and forth, you're gonna have gum bleeding, right? It's the same thing here, right? The fact that I have the electric toothbrush doesn't mean that I'm gonna use it properly. If I am jamming this back and forth, there is gonna be bleeding. But you know, I'm not even gonna look at it, you guys. You look at it, tell me. And we have here Elizabeth. Elizabeth, you're doing an externship here with us. You've never seen something like this, right, Elizabeth?
Right.
Now, I'm not even gonna look at it. Tell me the color of what's coming out.
Yellow.
Yellow? Okay, there we go. Yeah, well, how come you hesitate? You don't know the color yellow? Yellow, why is it yellow? Because it's fat, right? Mm-hmm. It's fat and the fat is yellow, right? Yeah. That's what it is, right?
Yes.
Yeah, but is this the usual? Dan is our anesthesia provider. When you do, like, and you've been here with us for a while, but when you've seen liposuction done at other facilities by other people, what comes out of here? What color is that, Dan?
It's a lot more red.
A lot more red. Yeah, exactly. And why is it not red here?
Because there's no blood.
There's no blood, exactly. So the blood, even if it's a little bit of blood, it will completely stain the fat. It will be red, or in the best case, it'd be pink. And you know the beauty of this is that that's the very fat. So that's the very fat graft that you're gonna put in. And if you've seen doctors do this procedure, we're gonna put the fat inside your buttocks, right? It's a fat transfer of the famous BBL that we're gonna do here, right? But when you see the doctor and when you see me, please take a look and make sure. I want you to see that it's gonna be this very yellow, beautiful, oil-less and bloodless fat graft that's gonna go into her buttocks. So people say, hey, doctor, how come I did my surgery with somebody else, right? And I lost all of the fat graft. My buttocks were big, and then nice, and then 1 month went by, 2 months, and boom, I lost everything, right? Or the great majority. Well, I got news for you. Normally, you lose 30 to 50%, almost half of whatever is put in. So a lot of doctors, what they do is they put twice as much. So when it comes down, they still look good, right? Because a lot of the fat that they put in is not fat. A lot of the fat is fat and blood, or it's fat and oil. And then you can get an oil cyst too, right? Something that we never have, right? So our patients retain all this fat. Why? Because it's fat. It's real fat. And also, a lot of the fat dies. You know, 30 to 50% of the fat dies. That's also the reason why your buttocks get smaller afterwards, right? And I'm talking about like months after the procedure. Obviously, the buttocks are gonna everything's gonna get smaller as the swelling goes down, right? For the first week or two. But I'm talking about months after the procedure when you lose the fat graft. People lose it because, number one, what you put in there is not fat, but it's fat and blood. And it's gonna look pink when you see it. But you don't even see a speck of blood. Do you see a speck of blood in there, you guys?
No.
This is what we're talking about it before, right? And I was talking to Elizabeth, our extern, how the epinephrine clamps down the blood vessels, so there is absolutely no bleeding. It's crazy, right? You go and you fall. You're skateboarding or whatever, you fall, you hit yourself, and you do a little cut, right? And there's bleeding, right? But there's no bleeding here. How can that be? It's crazy, right? So the fat that we put in the buttocks doesn't have any oil, therefore you're not going to have an oil cyst. It doesn't have any blood, therefore not only you're not going to be irritating, because the blood, when it's outside where it belongs, when it's outside the blood vessels, it irritates the tissues. The tissues create a callus around it and pushes it out, like it would push out a bullet fragment or a piece of glass, right? But here with us, look at that. No bleeding, no oil. It's just incredible, right? And of course, much less risk of anemia, blood transfusions, reoperation for bleeding, infection, blowout fractures, oil cysts, and the fat graft retention, which is what we're talking about, is much higher. Why? Because of the factors that we discussed also, and the lack of trauma. Because when you do these and you're doing 10 cases the same day and you go at maximum speed with very aggressive big cannulas, there's going to be a lot of bleeding, a lot of oil, and yes, you can do the procedure faster and see many patients and all that, but that's not what we do here. We do the complete opposite of that. We're very meticulous to the point of being ridiculous. We go very slow and very calculated. And I don't destroy the fat cells, right? I'm very, very careful, because if you destroy the fat cells, then of course that fat cell is going to die, right? And so we use very, very small. The biggest cannula we use is a 4 millimeter cannula, so it's just millimeters. Right now I'm going deep in here, so I'm pressing to go deep, but yet, look, not a drop of blood. It's just unbelievable. It's unbelievable. And this is a very unique technique, and we love to do it. We love to show it to you also. We teach this to other doctors, so if you'd like to learn this bloodless technique, I just gave a conference at the World Association of Gluteal Surgeons in Miami with Dr. Miami, the famous Dr. Miami, my dear friend, Dr. Michael Salzhauer, founded the World Association of Gluteal Surgeons, and I am the CEO of that association. And we're teaching how to do the fat transfer to the buttocks safely under ultrasound. And that's something else we're going to talk about at the end of this case. But for now, this is incredible. It's a combination of things that we do here. It's not just one thing, but it's a combination of things to obtain this bloodless, oilless fat graft. Thank you so very much for your attention. Wow, so look at the fat that's going into the canister, right? It's all pure fat, right, you guys?
Yes.
And I'm going to let it go so you can see when it goes in fast. 1, 2, 3, go.
Wow.
Look at that. How does that look? Huh?
Pure yellow.
Pretty
fat.
incredible, huh? Yellow, beautiful fat. That's what we do here at the Cosmetic Surgery. Thank you. Wow, so this is not just one thing, it's many, many things that we do to obtain this bloodless, oilless aspirate, right? So it starts with the patient, what we tell the patient. So we tell the patient not to take any aspirin-like medication, no ibuprofen, no herbs, no vitamins of any kind for 2 weeks before and 2 weeks after, right? It's what the surgeon does. The surgeon doesn't tell the patient to take aspirin or ibuprofen or herbs or vitamins, and the surgeon does not give any blood thinners, right? Some surgeons do all that. They give you aspirin, they give you vitamins, they give you ibuprofen, they give you Motrin, right? For post-operative pain. Then they also give you blood thinners. It's common that the surgeon will give you enoxaparin. It's a medication similar to heparin. They do that to prevent a blood clot or to minimize the risk of a blood clot, right? And it's a good thing to do, and they should do it. But in our case, we operate differently, right? So the reason why they do that is because the patients normally are in severe pain afterwards, and they cannot walk. And if they cannot walk, they're not going to be able to prevent a blood clot. In order to prevent a blood clot, the best thing to do is to walk, and our patients walk out of here. You can see them on TikTok walking straight up the next day after a tummy tuck or a breast reduction or a BBL or liposuction. They just walk because they don't have pain. You can tell your patient to walk all you want, but the patient is not going to walk because the patient is in severe pain. But our patients don't have pain. Our patients walk. Therefore, we prevent a blood clot. And then the usual things that everybody does, but we go the extra mile. For example, these compression boots here, we go all the way up to here. Those are compression boots. Normally, most surgeons have seen they put the compression boots below the knee, but 80% of the blood clots come. I'm not qualified that though, and I say that there is studies that show that it doesn't really matter if you put it below the knee or above the knee. They have even done studies where they put it on the arms and it still works. So somehow that compression works. but to me, it makes sense that you would do it, so that's what we do. And we're extremely happy with the way our patients are doing. We never had anybody die. That's the one thing that can kill you. And I've been doing this for many, many years without any single death. So we're going to stick to it. I'm not going to change anything, because despite of whatever the studies show, my personal experience is incredible, with incredible safety, and I'm not going to change that. It doesn't cost me, well, it cost me a little more probably to get the thigh-high compression boots, but the key is not so much these, it's not so much the enoxaparin. The key is early ambulation, meaning walking early is gonna, your muscles contract when you walk, and you pump the blood. That's what prevents the blood clot. Your own muscles pumping that blood back into the heart, right? Now, when I do these, I'm gonna ask our anesthesia provider, Dan, that has been with us for a number of years, and what is the difference? How this technique that I have, this bloodless technique, the use of the tumescent anesthesia, how does that change the way you practice in comparison to if I was another surgeon and I wasn't doing much of the tumescent anesthesia? How does everything looks for you on your anesthesia side?
Well, since they're a lot more comfortable here, I don't need as much anesthesia.
Yeah, you can film it. Yeah.
So I don't need to give as much inhaled anesthetics. I don't need to. So yeah, as I was saying, less inhaled anesthetics, less opiates. So the patient doesn't require as much deepening. So they recover faster, they wake up faster, and they just feel better later in the day. So it's just easier on the patient and less risks or complications from anesthesia.
And why is it that you give less opioid medication, less narcotics, this less pain medication? Why is that?
Because they're extremely comfortable from the tumescent anesthesia.
Which is what I put in here, right?
Exactly.
Yeah, so they're extremely comfortable to the point that these procedures can be done without general anesthetic, right? But I like general anesthesia because what other advantages general anesthesia done this way offers the patient?
So because they're comfortable, their blood pressure doesn't go as high. So you put them at a very nice steady blood pressure so they don't bleed as much.
Look at that. Look at that. So this is not just me, him helping me out too, because the blood pressure is controlled, even though this particular patient has hypertension. But look at that. Blood pressure is controlled, everything. Keep going, Dan.
So she's not moving, she's not aware, so she's very comfortable. So there's no chance of her moving around and contaminating and causing an infection.
Exactly.
So it's just a lot safer this way.
A lot better, right? This combination offers a lot of things that are good for the patients. This is a technique that I developed over the years. I've been using this for many, many years, and it's really the best way to do this procedure. But it's a team effort, right? We all work here in a team. And look at this, huh? Look at the bloodless aspirate. So it's a combination of things, right? And so the patient has less nausea and vomiting. Why don't you explain why the patients have less nausea and vomiting with this technique?
Well, with less anesthesia, then there's less of a chance of having nausea and vomiting because the inhalation agents can cause nausea and vomiting. So when you give less of that, then you're reducing the chance of having nausea and vomiting.
And the way I explain it to the patients is basically, I used to do all general anesthetic before. Just him, nothing here, right? And then I changed to do all tumescent, just here, not there, right? And now we do both, but we do half of the tumescent anesthesia dose, and we do almost half of the general also. I don't know if that part is correct, but it's just an analogy, right? It's not totally perfect, but basically it's like a car. See, before I used to drive a gas car. That's him, right? Giving the gas, putting the patient to sleep, right? And then it's pretty good, and that's the way most doctors do it, I would think. And now then I just use an electric car, no gas at all, right? And now I use a hydrant, right? So the hybrid use less gas, less anesthesia, and less electricity also, and it's more efficient. You got it? So that's the advantage of these. Thank you. Okay, go. Okay, so look at all that nice fat going in, same as before. We're almost done with the belly. Yes, no significant bleeding, right? I'm gonna let it go on the count of 3. So you'll see 1, 2, 3, go. Look at that.
Wow.
Very nice, huh?
Mm-hmm.
So this is some just saline fluid here and tumescent anesthesia here. But
yes.
Look how clear that is. Incredible. Thank you. All right, so I'm ambidextrous, but this is my non-dominant hand, right? So if you're a surgeon, and even if you're not ambidextrous, you can try this as long as you go slow like this with your non-dominant hand. And you know what it is that by going slow, number one, you're going to learn that, you know what, you can do less trauma to the tissues by going slower, do the proper tumescent anesthesia, the things that we already discussed. But in addition to that, the risk of organ perforation, intra-abdominal or intrathoracic injury with injury to internal organs is something that we never had, right? But it's something that can happen. It can even lead to death of the patient, something that has never happened to us, thanks to God, of any surgery. We've never had anybody die and want to keep it that way. But my teaching here would be, again, similar to driving a car, right? So you're driving a car now like at 45 to 50 miles an hour, right? So very, very safe on the freeway, right? And I would say most doctors drive about 75 to 80 miles an hour. So maybe you'll have maybe 1 or 2 cups of blood loss. It's not such a big deal. You're not going to get, you know, like a blood transfusion from your own or a blood transfusion from the patient, you know. But basically, there is some surgeons that drive at 260 miles an hour on the freeway at full speed. Incredible, right? And there is going to be significant bleeding, you know, and you're going to need a blood transfusion from your own blood that's transfused back into you and blood of other patients, right? And you have more risk of intra-abdominal injury. Thank you. All right, so look how superficial I am. We're toward the end of the procedure, and look how the output remains absolutely bloodless. This is just incredible. Look how beautiful that is, right? And so, and then I'm going very superficial now. We already did the deep suctioning, and now I'm creating the lines here of the rectus abdominal wall muscles. Like it's an athletic look, high definition athletic look, but not something, she didn't want anything very, she doesn't want the, you know, the squares, right? She just wants a very nice dental definition. And for those doctors watching out there, I use a 4mm cannula for the deep tissues. It's a 4mm micro-air power-assisted liposuction Mercedes for the deep subcutaneous tissues. And I'm using a 4mm triport power-assisted liposuction cannula for the superficial tissues. But I don't know if you can tell already how she's looking, and look at the output. It remains incredible. Thank you. Okay, so we're basically toward the end of the procedure right here, and it's incredible. I'm going to show you what is called the pinch test here, and let me show you the pinch test, right? This is incredible. See, look at this. 0.5, 0.5, 0.5, 0.5. This is the pinch test. Look at on this side. See, 0.5, 0.5 centimeters. I'm talking about everywhere. I don't know if you can see from there. And I'm just finishing up here in the middle. We did these lines. We're going to show you photos, but we're almost done here too. Look, see, very, very, you know, look at that. And absolutely, look at the. We're almost done with the procedure. And notice the complete absence of bleeding. Look at that. Incredible. This is just unbelievable here at the Cosmetic Surgical Center of Cerrito. You better believe it because it's true. Look at that. That's like a neon pot, man. Almost completely bloodless, not a speck of blood. See? Incredible. See? That's what we do here at the Cosmetic Surgical Center of Costa Rica. This is something different, I would say very unique technique, right? Dan, have you seen these people do liposuction like this? With completely bloodless, other than
Not
me?
that clean, no.
Incredible, huh?
It's a lot bloodier in other places.
Oh yeah, of course, yeah. I personally have never seen anybody do liposuction like this in my entire life, never. And if you know, once you go look at patients, right? If you see somebody doing it like this, and it's this spot like that, you know, go over there, because they know something that I don't, maybe, but this is an incredible thing. That watch the surgeries and you'll see like all the way down there, no bleeding at all. Incredible, see? And I use both hands, so that also limits injury to the surgeon, right? Thank you. Oh, look at that waist already here. She's on the lateral decubitus, meaning she's on the side, the buttocks are over here. But let me show you, this is the pinch test. Look at that, 0.5 centimeters everywhere we go. Look at that, and in the front too. This is the side, this is the waist, everywhere we go. Look at that, incredible. Thank you. Wow, and so this technique is also very comfortable for the surgeon, right? So it avoids, you know, the injury to the patient, number one, right? So because when we do this in a controlled manner, it's like driving a car, right? You're driving slow, the chances of you getting into an accident are less, right? If you go very fast, you can basically, you know, lose control of the vehicle, go to an unintended area, right, and crash. The same thing is here. I think those cases where there is injury to the patient, intra-abdominal or intrathoracic injury, something that has never happened to us, is usually the result of a surgeon that is already tired. That's probably on his 10th day for the day. That is probably on a Friday night, just like tonight for us, Friday night. And they're tired. We just do one case or two at the most per day, so we're not overworked. And I have the luxury of doing this in a very controlled manner. So what this does to the patient is incredible. You can see that bloodless aspirate, much less risk of internal organ injury, which we never have. But for the surgeon, there is also advantages because I'm not sweating the case, I'm not sweating it, I'm not at it and tired, and I'm very comfortable here. And so look how I'm just relaxed, right? I straight up, no big deal, right? So less risk of injury to the surgeon as far as the result of repetitive trauma to the wrist or to the elbow or to the shoulder. Those are the most common injuries, right? Maybe the neck also, from maybe bending over like this, I don't know. But usually, this is also good for me. And look at this, toward the end of the case, yeah, and so very, very comfortable. We're toward the end of the procedure, we're almost done, right? And why don't you show them the pinch test right there on the waist. We're not even done yet, but it's like this, see? So, we still have some fat here. So it's not, we still gotta do some work. Compared to the other side, no, it's good. Compared to the other side, we still have to do some work. Look at that, see, you still, and, but.
Look at this beautiful yellow fat.
Yeah, it's incredible. The fat is yellow and nice, see? I thought we were almost done with this, but we still got a lot to do, like compared to the other side. Yeah, good thing. Do the pinch test, right? So basically see if there's a lot of fat there, but look at this, see? Incredible. And so we already gave her a very nice waist, but guess what? She still has some fat, see? And notice this, and we're gonna compare it to like we did on the other side where it was like totally thin. See, now we still have fat here. Incredible. Thank you. So her buttocks are over here, she's on her side, this is the waist. Notice the difference. Remember how we did the pinch test and it was like that big? Now look at this, see? Yeah, this is it now. See, I couldn't do this before, right? Even if I tried, I did try. I thought we were at goal, but no, this is goal. The other one was, you know, everywhere we go. Look at this, see? And we can do it this way too, see? You see, this is the waist, buttocks over here, look at this, see? And see this, see? That means, you know, it's very even. Even Steven, this is called the pinch test. Incredible. Everywhere you go, see? Like, incredible. Thank you. Wow, so now we're putting the fat graft in the buttocks. So I'm looking at the patient. I'm looking at the ultrasound, and I'm also looking at what's going in. Look at that beautiful 100. And so we put 100 ml already of this oilless, bloodless fat graft. Is incredible. Thank you. All right, and so look at that fat graft. It hasn't been processed in any way whatsoever. We haven't washed that fat. We haven't processed it in any way. This is the way it came out. This is the way it's going back into her buttocks. And I'm looking at the ultrasound. I'm looking at the patient, and I'm looking at what's going in. That's incredible. Fat graft without any blood, without any oil. And we put 100 in each side, and then I move to the other side. I want to show you on the ultrasound now how this all looks. It's incredible, okay?
All right, we're doing ultrasound guided gluteal fat transfer. This is the patient's skin. This right here is the superficial gluteal fascia. This straight white line is Dr. Patino's cannula. He's going to wiggle it for us. Wiggle, wiggle. And then we have the striated muscle right here and the deep gluteal fascia. You can see that Dr. Patino is in the deep subcutaneous space above the deep gluteal fascia, but below the superficial gluteal fascia, right here in the middle.
How big is that space, Nicholas?
So this is 4 centimeters right here, and each of these is 1. So we're looking at maybe 1 centimeter.
Wow,
Yeah.
that is very tight. That's
Very
why
tight.
you need ultrasound. I'm going to withdraw a little bit the cannula so you can see the tip of that cannula, okay? And it's just incredible. You see the tip of the cannula there coming back? All right, so focus on that tip. And what's going to happen now?
So we're going to see a bolus of fat enter as soon as he starts transferring fat. And what we're going to see on the ultrasound is a cloud, right? It's going to appear gray here, and it's going to push down on the deep gluteal fascia and up a little bit on the superficial gluteal fascia.
All right, let's do it. 1, 2, 3.
All right, so we have fat entering the space. See this cloud right here? This is all the cloud of fat. Right there you see it, and it's pushing down on the deep gluteal fascia as it occupies this deep subcutaneous space.
Incredible. Very beautiful. Look at the cannula back in there now. And I'm going to withdraw and do the same thing.
All right, see the fat? Thank you.
And we'll do the same.
Right, so we're on the other side. We have the patient's skin. We have the superficial gluteal fascia. This straight white line is Dr. Patino's cannula. The point is over here. This is the deep gluteal fascia. This is the striated muscle. It's a beautiful image.
Beautiful anatomy, isn't it?
Yeah.
I want to make sure that this is on, and I'm going to wiggle the cannula a little bit so you can see it. Let me see.
So we're right here in this plane.
Yeah.
So we're above the deep gluteal fascia and below the superficial gluteal fascia. We have Dr. Patino's cannula right here.
And I'm going to wiggle it for you. So where's the point of that cannula?
We have the point right here.
Okay, so I'm going to go focus right on that. 1, 2, 3, go.
See the cloud of fat? Right here, and it's pushing down on the deep gluteal fascia as fat enters this deep subcutaneous space.
Incredible. Beautiful. Incredible. Look at that.
Yeah, it's pretty cool to see it in real time, what's happening with the fat injection as it occupies the space.
Yeah. It also guides you, like for example in this area, there is not a lot, so I'm going to go give it some more there. See?
Right here, you see that cloud coming in? Again, right here and right there.